Now I'd like to introduce Nancee Jaffe, who is our registered dietitian in our Division of Digestive Diseases, and she's been with us now for about 2 years, yeah, and we've been so happy to have her. In fact, patients sometimes come to see us specifically so we can refer to Nancee, and she's been great, and she's going to educate you on a couple of topics, particularly nutritional disorders. Nancee.
Hi, everyone. Thank you for being here today. I'm very excited to be talking about nutrition and GI diseases, especially since we're doing this in a case study format. I felt like it really gave me the opportunity to focus on some topics that are of general public interest, so things that your patients are probably bringing into the clinic all the time. So my first case study, I'm going to focus on irritable bowel syndrome and a diet called the low FODMAP diet, which if you have not heard of this diet yet, you will be. This is probably going to be the new diet craze after the gluten-free diet. This one actually has some really good research, and we'll talk about how useful it can be with your IBS patients. And then we'll also look in the second case study on digestive enzymes and probiotics, because I know I have a lot of patients that come to see me and wonder about, what is a probiotic? Should I be on it? How do you know which one to buy? And then digestive enzymes, which I find really useful in my practice. So we'll kind of dive into that. So to start with, let's do a little question for the audience. So I apologize if you haven't heard of the low FODMAP diet, but give this question a shot anyways. How long should patients be on the low FODMAP diet? A, until their symptoms disappear and then they can come right off. B, about 2 weeks and then do a reintroduction phase. C, 6 weeks and then do a reintroduction phase. Or D, if it works, stick with it. All right, so most people think that this is a diet that patients should be staying on for the long term. Actually, if we can move to my slide, you'll see that the answer is C. So generally speaking, this is an elimination diet. So we will put patients on this diet for a 6-week period of time, and then we will do a reintroduction phase, because as you'll see, it's a very difficult diet to follow. It would be very painful to keep patients on this diet for huge periods of time. So case number 1, we have a 36-year-old female who presents with IBS-D diarrhea for the past 2 years. She has symptoms of abdominal pain and bloating, gas and diarrhea, as well as some anxiety and stress because she just feels overwhelmed by her symptoms. She feels like she doesn't know how to manage them. She feels like they come and go whenever, and she has no control over it. The patient at this point in time wasn't interested in medications, which was a big part of why the doctor had sent her to me. And she had tried some of the traditional IBS methods that we think of, such as reducing fat and sugar in the diet, regulating the meal plan, and nothing had really worked for her all that well. I make note that she was tested for celiac disease with both serologies and genetics 6 months prior to seeing me, because she had decided to place herself on a gluten-free diet about 3 months before seeing me, and she said her symptoms got about 50% better. Other than that, she had tried removing dairy from the diet, which she thought she had moderate good results with. The problem was, she admitted her favorite thing to eat was ice cream and frozen yogurt, and she just couldn't stick with getting those out of her diet. Other than that, she hadn't really tried any dietary changes. When I did a diet recall with her, it became apparent that when she ate foods like watermelon and onion, apples, and of course the ice cream, that she seemed to have symptoms. So the question becomes, is this an appropriate candidate for the low FODMAP diet? So let's talk about what the low FODMAP diet actually is. So FODMAP is an acronym that stands for a bunch of small chain sugars that ferment very rapidly in the gut and can contribute to GI symptoms. The fact that they're small is actually very important, because it means that they move very quickly and they can take water with them, which can be part of the osmotic diarrhea effect we see with our IBS-D patients. Also, they ferment quickly, which means they can cause some of those gas and bloating symptoms that we see so regularly with our IBS patients. So the sugars that we're mainly looking at with this diet are 5 specific sugars: our fructans, galactans, lactose, fructose, and our polyols. And I'll explain what those mean. So this is the low FODMAP diet, actually in its simplest form. And I know that this does not look very simple. So you can see up at the top that we've got our 5 different sugars listed. The lactose, fructose, fructans, and galactans are in the same column, and our polyols. And the main thing I want you to notice is that most of our favorite, usual, typical foods are on this list. So you've got everything from wheat, barley, and rye, which, if you'll remember from Dr. Lewis's talk, are also the ones that contain gluten, okay? So the same grains that contain gluten also contain fructans. So oftentimes we have patients who have a fructan sensitivity, not a gluten sensitivity. There's also fruits like apples and watermelon and peaches, our vegetables like mushrooms and artichokes and asparagus, pretty much all of our legumes, some of our nuts, and actually a lot of our sweeteners like honey and agave, which we see very commonly in food products. So you can imagine this is a little bit of a difficult diet to follow. So what is the research behind the low FODMAP diet? What's the evidence? So this was a diet that was created in the early 2000s by a dietitian in Australia. And basically, the research started coming in 2006, and we saw that when patients were put on the low FODMAP diet for about a 42-week interval, that they were showing pretty good symptom relief, about 70 to 75%, and this was mainly in our IBS, diarrhea, and mixed patient population. We saw the same thing happen in 2 different research studies that were done in 2008 and 2011, where the FODMAP diet was pitted against the NICE diet, which is the UK's National Institutes for Health and Care Excellence diet, which is kind of our typical IBS treatment, the regular meals and the fatty food limitations and sugar limitations. And again, the FODMAP diet won out. Again, in 2014, the diet was pitted against kind of what patients were self-restricting, so either their habitual diet or kind of the typical Australian diet. And again, the low FODMAP diet had overall better symptom relief. So there's actually pretty good research for putting patients on this diet. So what about gluten-free versus the low FODMAP diet? How do we know which one to talk with our patients about? So this is actually a really great study that was done just last year, where the same people who had created the diet decided to look at patients who were deemed as having non-celiac gluten sensitivity or IBS, and they ruled out celiac disease for this patient population. And then what they did is they had them go into a low FODMAP criteria for 2 weeks. So everyone who was in the study was put on the low FODMAP diet for 2 weeks at first. Then they were divided into 3 different categories. They were either eating a high gluten muffin, a low gluten muffin, or a placebo muffin, which happened to have whey, which technically has lactose in it. So technically they were putting them on one of the FODMAPs as well. And what they found is that all patient groups did better when they were on the low FODMAP diet, and all of them did worse when they were put on either the low, high, or placebo. So what this really kind of tells us is that non-celiac gluten sensitivity, yes, it probably does exist, but is it actually gluten that's the culprit, or is it these fructans that are the culprit? And it wouldn't shock me if in the next 5 to 10 years we're changing the name of non-celiac gluten sensitivity to be something like fructan sensitivity or fructan intolerance or something along those lines. So it really is something to kind of make a note of. So who should we be thinking about with this diet? So of course we want to be looking at our IBS, diarrhea, and mixed patients. The research isn't great for IBS constipation, although anecdotally a lot of dietitians say that they get good results with it. It can definitely help with the bloating and gas problems, but it's not generally as helpful with the constipation side. This is also a great diet to be using with our SIBO, or small intestinal bacterial overgrowth patients. It makes a lot of sense that when these patients are put on an antibiotic to help kill the bacteria, that they're also starving the bacteria at the same time by eliminating the sugar source, the fuel that these bacteria like to grow with. It's also really great for inflammatory bowel disease and celiac disease patients who are clinically in remission. So you had heard Dr. Haas speak earlier that some of these IBD patients can have IBS at the same time. So clinically, they're in remission, their sigmoidoscopies look good, their lab results look good, but they're still having bloating, gas, maybe some diarrhea. The low FODMAP diet can actually be a great diet protocol at that time to place them on. Same with our celiac patients who are strictly following the gluten-free diet. They've got clinical remission in terms of their biopsies and their serologies, but they're still having continued symptoms. We see a lot of fructose intolerance and lactose intolerance in this population, so it makes sense to also think about this diet protocol. So back to our patient, she was placed on the low FODMAP diet. We did it for a 6-week period of time. And as you saw earlier, this is a difficult diet to follow. And I find that just putting a patient on this diet for about 2 weeks, which some dietitians choose to do, I find that most patients can't comply with the diet that quickly. So oftentimes they continue to have food in their diet that they don't realize has onion and garlic in it, or has honey in it, or has some sort of sweetener that they didn't realize. So oftentimes it's easiest to have them work with a dietitian where they're reading food logs. So the way I work with my patients is I give them not only that list that you saw of the high and low FODMAP foods, but they also get grocery lists and meal planning ideas. I give them brand names that they can actually go to the store and buy. We talk about different tools and online message boards that they can go to, places to get good quality information on this diet, and then have them keep a 2-day food log for every single week that they're on the diet, because that means that I can follow them and make sure that they're complying with the diet. Unfortunately, small amounts of these sugars can lead to gas and bloating, and so if they're not complying fully with the diet for the 6 weeks, they'll never see the full benefit, and so it almost is a wasted effort. So luckily, this patient, we had good follow through with her, and when she came back in at her 6-week follow-up appointment, she had a vast symptom improvement. She was 80% better in terms of the pain and diarrhea, and she was about 95% better with gas and bloating. She also said that her anxiety symptoms had gone down because she was feeling so much calmer. She felt like she had a good understanding of what foods to eat and not eat. She felt like she had more symptom management, so she was pretty happy. So the next step is, what do we do in terms of the reintroduction phase? We don't want to keep these patients on this diet long term. And especially, we've got 5 different potentially culprit sugars here. Not all of them are going to be the problem. So I find most patients have 1, 2, or 3 sugars that are really problematic for them, not all 5. So we can end up liberating the diet at the end by bringing those sugars back into the diet. So there is no protocol at this point in time for the reintroduction phase. And from talking with the people who actually created this diet, they're not actually planning on working on that part. The reason being that it's so individualized. Each patient needs a little bit different of a tactic. What I choose to do with my patients is divide up the 5 sugar categories and have them try small amounts over a period of time, so that we can not only figure out which sugars are problematic for them, but we want to know a threshold as well. Because what if they can handle small amounts of fructose, but when they go in too high of an excess, that's when we have a problem. It means that we could be putting some foods back into the diet that otherwise would be missed and just eliminated with no reason. She also was having some anxiety issues, so I did talk with her about mindfulness meditation. There's pretty good research about the mind-gut axis, which I'm sure Lynn will be talking about later, and it's very helpful for just kind of helping these patients to stay present and not get too overwhelmed by their symptoms. So we'll move on to case number 2 and another question. So the question is, when should probiotics be given to a patient? A, after antibiotic course. B, international travel. C, major dietary changes, and this can include things like living abroad for a month or being in a place where the water or the soil that's used to grow food is different. Increased episodes of extreme stress, so this can be anything from a divorce to getting fired to work and family issues, or all of the above. Excellent. So this was an easy one. I'm glad everyone got it. So yes, the answer is D. Perfect. All right, so let's move on to our case. So we've got a 23-year-old male with hard stool, gas, bloating for about the past 3 to 5 months. He said to me that he started recently working out for 2 hours every day, or 6 days a week at the gym, so he's really trying to get buff. And while he was at the gym, some of his weight training buddies told him, hey, you should try this paleo diet. So he tried the paleo diet starting about 4 months ago, which included high protein, high vegetables, no grains, no sugar, no dairy. He also expressed that he had been to Costa Rica 5 months ago, where he stated that he had had a bout of really bad diarrhea that was followed by some constipation. He had taken antibiotics while he was abroad. The doctor who had referred him to me had already tested him. He had no bacterial parasites that they were aware of. He said his bowel movements at that point in time were just 1 every couple of days, and that they were, he called them rabbit pellets. They were really hard to pass. And when we did his diet recall, it showed that he was eating 16 ounces of animal protein per day, which is over 120 grams of protein, and a large volume of what we call cruciferous vegetables, which includes our broccoli and asparagus and cauliflower. So let's talk about the research on digestive enzymes. Unfortunately, there's not a lot to talk about in this area. Most of us are pretty familiar with the pancreatic enzymes that are used to treat things like cystic fibrosis and chronic pancreatitis, and this really focuses on our macronutrients, so proteins and fats, as well as our carbohydrates. But there's little research on the carbohydrate-specific, sugar-specific, fiber-specific enzymes that can be really useful for some of our patients. Some of the research that does exist is on such enzymes as alpha-galactosidase, which is used for specific oligosaccharides, mainly the galactans, which we saw when we were talking about the low FODMAP diet. So that includes our raffinose and our stachyose. And even though you think you might not be familiar with this enzyme, this is the one that's used to treat the gas that comes from eating beans. So it's actually fairly common, and a lot of people use these to kind of treat when they're eating, Mexican food. Lactase or lactase deficiency or lactose intolerance, we have a fair amount of research on. Most of us are pretty familiar with it. And again, there's enzymes on the market that are specific for treating this disease state. There's also sucrase deficiency, which is seen in congenital or acquired sucrase isomaltase deficiency conditions. This is generally something that is seen in young children. They have failure to thrive issues, rampant diarrhea, lots of malabsorption, but it can be seen later in life. And in those cases, we see a lot of diarrhea as well as bloating and problems, specifically when a patient has a high starch meal. So the answer to this one is you put them on a sucrase enzyme alongside a low sugar, low starch diet. And then there's also some new research that's happening because of kind of the craze that's happening with probiotics, looking at these different fibers and what enzymes help to break them down, including xylanase, which helps to act as a prebiotic source for our microbiota and can help with microbial growth and be kind of excellent for helping with gas and bloating symptoms as well. So in terms of enzymes, there's over 2,700 enzymes in the body, and the ones we're most interested in are the ones that help to regulate our digestion. So they help us to break down food so that we can actually appropriately absorb it. So what should we look for in patients who might not be making the amount of enzymes that they need to break down their different food stuff? Some of it is undigested food particles in the stool, so you can ask your patient when they eat things that are high in fiber content, are they noticing lots of stringy parts and pieces? Some of it we expect with things like lentils and corn, but it shouldn't be consistent all the time. So if there's lots of big chunks of food in the stool, that could be a sign that they need an enzyme. Also, if there's some sort of an intolerance or sensitivity, so we had mentioned something like the lactose deficiency. And then also, anyone who has excess gas and bloating, this can be something useful, especially if they're eating high fiber diet. So what do we look for with our enzymes? Because there's a lot of different enzyme types on the market. So this is just an example of one label that you might see on an enzyme. So the types of things I generally look for is I want there to be a good basic pancreatic enzyme, so our amylase, our lipase, and our protease. But we also want a wide range of sugar and fiber specific. So you'll notice in there the xylanase and the alpha-galactosidase, the lactase, so some of the ones that we had mentioned earlier. The other thing I look for is a high unit per capsule, and just to give you an example, this is a product that I would not use, and the reason I would not use it is that if you look at the alpha-galactosidase, it's only got 125 gal-U. If you look at other products on the market, they're closer to around 500 or 600. So this might not help a patient who is trying to work with the beans and the cruciferous vegetables, such as our patient. This product probably would not help them very much. We also want to look for no binders and fillers. We're talking about GI patients here. So the last thing we want to do is cause more gas and bloating by giving them a supplement that also contains milk or soy or wheat or something along those lines. So you can see in other ingredients, this one has nothing. It's just the cellulose capsule, that's all that's in it. So that's the type of thing I look for with this type of supplementation. So what about probiotics? We've got a lot more research on our probiotics. One of the important points is we know that there's a signal that goes on between the intestine and the nervous system. And there's a lot of research that's coming about that shows that the gut microbiota may play a role in this. And so when there's a change in that gut microbiota, this could potentially cause problems, especially with our IBS patients. And so using things like pre and probiotics could be helpful in this patient population. There's also research that shows that after an antibiotic therapy, especially in our patients who are more at risk, like our elderly patients or immunocompromised patients, that we want to think about a probiotic to help restore that important intestinal microbiota. And then, of course, we know our westernized diet with its high fat, high sugar, high salt intake tends to change the microbiota. And I believe I saw one study that said as quick as 4 days. So eating, a lot of, Happy Meals every single day for a couple of days is going to change the gut microbiota, and not for the positive. So this is another place where using a probiotic can be very useful. So in terms of probiotic, not only are they important for digestion, they can really help regulate the bowel movements, and they also help with our immune system. So a lot of our immune system is in our gut, so it's important that we take care of that. We had already talked about in the quiz when you should consider using a probiotic. So definitely after a course of antibiotic treatments, international travel, changes in diet or living location, and then also you can consider doing it after there's been a hit to the immune system, such as after a cold or flu. So again, what do we look for when we look at these supplements? Because if there's a lot of digestive enzymes on the market, there's 4 times that amount of probiotics on the market. So the types of things that I look for is I want to see the types of species and strains that we believe to be most helpful at this point in time. Lactobacillus is the main type of bacteria to be found in the upper GI, so it's in the stomach, duodenum, and jejunum, whereas we see more bifidobacterium in the lower areas where the ileum and the colon. So I usually am looking for a healthy blend of those 2 types of bacteria. I also am looking at the dose. So you can find doses from as little as actually about 500 million all the way up to 900 billion. So there's quite a wide variety. The big thing to keep in mind is that the initial symptom of taking probiotics is a little bit of gas and bloating, because these bacteria are trying to make a home in the gut. And so if a patient has never taken a probiotic and you throw them on 100 billion bacteria, they may have some pretty severe symptoms. So I always say start small, give them about 2 weeks. If they're really having a lot of symptoms after 2 weeks, it was too high a dose, pull back. If they're doing okay, you can actually consider increasing, because you need to find what is the perfect dose for that patient. And I usually find that keeping them on a probiotic for about 1 to 3 months is about all they need, and then you can slowly start weaning them off. If they start to have symptoms again, you can always put them back on, but most patients do well, and these products are very expensive, so it's nice if we can keep that cost down. Another thing we want to check for again is that there's no GI triggers in our supplement. So again, this is not an example of a type of probiotic that I would recommend. Why? If you look at the contain statement at the bottom, you see milk is listed there. So this isn't a great probiotic for anyone who has an issue with lactose. And then there's also a proprietary blend that has fructooligosaccharides in it. Those are our FODMAPs. So those actually act as food source for the bacteria, but if the bacteria doesn't consume all of those, guess whose bacteria does? So that's going to be your patient. So we really want to make sure that it's a clean probiotic that we're giving to these GI patients. So what did we say to this patient? The first thing was we had to lower his protein intake. 120 grams for this man was, I believe, about 5'7". It's way too much. So that was probably contributing to the constipation a little bit. I started him on a really good broad spectrum probiotic. Because of the foreign travel, I wanted to make sure, and the antibiotic use, I wanted to make sure that we kind of got his gut repopulated. I started him on a digestive enzyme as well, explained to him what types of food the digestive enzyme is useful for. So since he was taking in those large amounts of cruciferous vegetables, I made sure to put him on one that had a high dose of the alpha-galactosidase, and that he take it at the first bite of every meal. If you take it 15 minutes after or 15 minutes before, it's been broken down in the system and it's not going to be utilized properly. And then I also did mention to him psyllium husk, because it's great for managing those hard stools, and that was just kind of something he could add on if you wanted to. So when he came back 6 weeks later, he had done all of the things I had suggested, and he was having regular bowel movements again. He had a decrease in his gas and bloating, not only from using the enzyme, but just changing up which vegetables he was using. So he was choosing vegetables that were not as high in gas promotion. So just the take-home messages from my talk, the low FODMAP diet is a very useful diet. It's something that we definitely should consider with our IBS patients, especially when traditional methods have failed, and this is particularly useful in our diarrhea and mixed IBS patients. But of course, thinking about it for your SIBO patients, your non-celiac gluten-sensitive patients, your inflammatory bowel disease and celiac disease patients when they're in remission, this is also a great diet protocol. And again, I really do recommend you work with someone who knows the diet well, because I've had many patients come into my office shaking with the one-page handout, and they're like, I don't know what to do with this food list. So you want to make sure that they're really getting the full spectrum of help they need for following this diet and following it well. In terms of the probiotics, again, we talked about the importance of looking at the CFU, or the colony-forming units, which is the amount of bacteria that's in each one of those capsules, as well as the species and the strains, the expiration date, and no fillers. So all of these things are important to look at. And then we talked about when to use them. Same with the digestive enzymes, making sure that it's got a pretty wide variety of the enzyme types, especially for the sugars and the fibers, making sure the amount is a good quality amount, no fillers, and that it can really be utilized with any patient that's having, gas and bloating, undigested food in their stool, or food intolerances. So hopefully you have some more talking points with your patient now and understand a little bit more about digestive enzymes and probiotics in the low FODMAP diet. So thank you.